If you're an athlete dealing with a knee injury and your physical therapy clinic doesn't have one of these, just run out the door. After the initial phases of a knee injury, and it's safe to load the muscles, we need to load those muscles, not just activate them. Quads atrophy, meaning they get smaller, especially after major knee injuries like ACL, PCL, meniscus, surgery, or even just minor damage or strains. Athletes lose capacity to do the tasks that they could do before, even the most simple ones, like think about lunges, or if they're hockey players, skating, football players, running, they lose that capacity, and especially they lose confidence. The biggest thing I see is a lot of athletes are not confident on their knee, even when their knee is technically strong enough to perform work. And that lack of confidence is going to transfer on the ice, field, whatever it is. Traditional physical therapy or physiotherapy, we know notoriously underdoses exercises, especially for athletes. Most of the literature we have and most of the clinical things that we've done in practice in school are for the general population or even in older individuals. If you're watching this, chances are you're probably a high performance athlete or even a weekend warrior. You're doing more than the general population, so I would put you in that top 10+%. With an athlete, we often have deadlines, return to play protocols. We want to make sure, especially for our top athletes that are getting paid, that they're not losing their job because of their injury and they're not playing with a lack of confidence, and their bodies are able to withstand the forces and the rigors that their sport demands. And even things like a back squat and front squat, which I absolutely love, we're often limited by the spine and form where we can't really load up the muscles. For reference, I can back squat 275 pounds for 10 reps relatively easy, but I can't back squat 9 plates aside for 10 reps like I can on a belt squat. What this means is the belt squat allows us to load the quads and the knees without the positional rigors that other barbell lifts or dumbbell lifts required. It's unlikely that we're going to be holding 300-pound dumbbells in each hand to load up the quads. This way, the limiting factor becomes the strength of the knee and not the strength of other body parts. Direct comparison shows that the belt squat can actually eliminate around 50% of erector activation and load while maintaining the same quad stimulus, which is excellent if our goal is to load the heck out of the quads and not perform things like a compound lift. Now, I love squatting, I said it before, time and place, right? But when we're coming back from an injury, we need to get this leg as strong, or the injured leg as strong as we can, as fast as we can, and then we can start to add in other compound movements. If we can get greater extremity loading and stimulus into the targeted muscles without having to worry about other factors, then we need to hammer it home, and the belt squat is perfect for that. One thing I see a lot of in my youth athletes is patellar tendonitis or even Osgood slaughters. With a youth athlete who's dealing with a knee injury, they may not have the best technical form to perform a back squat to the standard that we'd like yet, especially when they're dealing with injury and they're being cognizant of the weight and the load that's going into their knee. With a belt squat, we can take out most of those technical worries and start to progressively load them. And not only can we do bilateral things, but we can do unilateral things to dose the heck out of that involved knee. And a major key issue that traditional PT doesn't talk about that I mentioned at the start is that confidence factor. If you have a youth athlete who's maybe this is their first time dealing with a knee injury and they've missed some time away from the ice or the field, they're not confident. If you can start with 1 plate aside and over the course of your rehab, you have 6, 7 plates on, that athlete is going to feel way more confident. They're going to be trusting in themselves and their knee to go through the return to sport protocol to get them back on the ice or the field. Plus, they're going to have way more buy-in to your rehab protocol. Now, I can put an athlete and give them Polaclin step downs with 10-pound dumbbells, and maybe they progress to 20. Yeah, that's great, and it's a very awesome exercise. Again, time and place, but there's nothing like stacking up weight plates and having that rise to your confidence. We see it here with the athletes that aren't injured. When they crush a PR in the belt squat, they're bragging about it. I don't think anyone's bragging about their clamshell PRs. So if you're an athlete dealing with injury and you need to find a clinic or a gym with proper equipment, look for the belt squat. One of the things that I do when a remote athlete is looking for another physio to be referred to, I always ask them, do you have a belt squat? And most of the time they say no. And as a clinician and a hockey-specific physical therapy and rehab expert, it's about the athlete. Regardless of the cost of this machine, I need to make sure my athletes have the tools that they need to be successful. I'm going to walk you through the exact protocol that I used for a 15-year-old Tier 1 AAA hockey player, probably going to get drafted to Major Junior this year. He was dealing with some knee pain, some patellar tendonitis that he suffered from playing tennis this summer. First thing we did were belt squat isometric holds. We took about 60 to 70% of his perceived max because he wasn't at a point where we felt safe to test his 1 rep max. So we took his back squat, we extrapolated down, and then we played around a little bit with the weights. We started off with 5 sets of 30 to 45 second holds. And then from there, we worked on accumulation, where the goal was to accumulate 5 minutes regardless of how many sets it took. So if it took him 20 sets to get 5 minutes, perfect. If it took him 2 sets to get 5 minutes, perfect. After 2 weeks, so the inflammatory phase has begun to end, the knee is beginning to heal, it's towards the middle phase, the subacute phase, we worked into eccentric loading, so we still took around 60 to 70%. Now the goal was 3 to 4 sets, 6 to 8 reps of slow controlled eccentrics, focusing on full range of motion, full stretch to the knee with as much load as he could tolerate throughout that training block. That phase ended at about week 4. From there, he went into explosive split squats. So we had him in a staggered stance, and everything he was doing was driving the belt squat away, being as powerful and as dominant and explosive as possible so we could replicate that intensity that he had on the ice. We added in a lot of gastroc and soleus work, so our calf muscles, they attach on our knee. People tend to forget about them, specifically with injury rehab. So we added some single leg isometric, single leg explosive stuff on both the belt squat and the turf. If you're wondering about hamstring loading, yes, we did load the hamstrings. We just weren't doing it on the belt squat. We were doing the significant amount of RDLs, Nordics, and glute ham raises. So if you're a clinician or a coach who works with athletes, the belt squat needs to be in your training equipment set. If you're an athlete looking to train or rehab, make sure that facility has a belt squat. You need to be able to properly load the tissues, and the best way to do that without worrying about positional faults or excessive spinal loading too early is the belt squat. If you're an athlete dealing with an injury, reach out to me at ghostrehab.com. It's exactly what I do. It's exactly what I treat. Not only do we do things in person here in Grand Rapids, but we do things remotely for athletes all over the world. Thank you for watching this video. If you enjoyed it, like, comment, subscribe, or just watch this video that's up here. The YouTube algorithm is pretty smart, and it probably means you should watch this one.